Welcome, and thank you for attending today's webinar, Staffing for Success. My name is Lori McKee. I am a consulting manager for Eide Bailly. I am a nurse by background. I also have my master's in healthcare administration, and I have extensive experience in leadership in multiple areas of critical care or acute care, excuse me. I've been with Eide Bailly for about 1.5 years, performing operational and productivity assessments for critical access hospitals and many other areas, but today we're focusing on critical access hospitals. And our objectives include identifying common staffing practices affecting our productivity, looking for solutions that can help our organizations improve productivity, and presenting some services that Eide Bailly can provide to assist your organization with staffing and productivity goals. So talking about common staffing pitfalls, I labeled this slide. Really, as we look at appropriate staffing levels, they play an important role in our mortality rates, unplanned events like falls, complications such as infections, as well as our length of stay. So to accomplish all of these things doesn't always mean that we just need to staff more. Since nursing is typically our largest employee work group, most of your organizations, it probably accounts for almost 40% of operating costs. We need to start thinking out of the box and work as efficiently as possible without compromising our quality of patient care. So there's a lot of things we need to take into consideration when we think about staffing. Patient acuity, the number of admissions, all the activity on a shift, like number of admissions, our discharges, transfers, skill level of staff, the layout of our unit. Do we have a centrally located nurses station? Do we have wings, pods, availability of technical support, other resources? So I'm going to share with you some of the things that we commonly see as we are on site at different facilities and we perform operational assessments. I've broken it down by different units, starting with a med-surg unit. Really, care delivery systems haven't changed over time. Staffing's not adjusted to census or patient acuity. We put out our schedules and units are staffed with the same number of staff regardless of how many patients are on the unit or the acuity of patients. So we're still staffing a charge nurse who doesn't take patients, whether we've got a census of 2 or a census of 20. Nurses are assigned the same number of patients, and whether they're an acute patient or a swing bed patient. We're just not taking into consideration the level of acuity of the patient. We've seen a lot of variations and versions of acuity systems. Some are very good. A lot of them are homegrown. There's a lot of different versions. Some people have spent a lot of time and research into developing a really good acuity system. And some are just really nurse aid duties and really don't even take into account RN functions. Low census policies are just non-existent, or if they do exist, we're just not following them, and staff aren't being sent home when our census really doesn't justify having that number of staff on the schedule. And hours aren't allocated correctly when nurses are working multiple units. We know nurses float between OB and ED or ED and med-surg, but it's really difficult for them to clock in between, especially if they're going back and forth frequently in the same shift. So when we go to analyze hours and we really want to get an accurate picture of productivity, hours per patient day, whatever our statistic is, it's really difficult to capture that accurate picture of productivity. And then staffing for what ifs, and that list of what ifs is endless. Maybe it's staffing a nurse, a labor and delivery nurse for that in case a laboring patient comes in. So we're staffing her without any patient assignment, but she just needs to be in-house because we may have that laboring patient come in. ED is another unit where we commonly see staffing for what ifs. Trauma, motor vehicle accidents, mass casualties, all of those things that we know we need to be ready for in the emergency department. And we know we need to have robust staffing plans to address all of these scenarios, things that may happen within a shift, but never can they be a one case fits all. Need to be very specific And we need to go back and think about census, acuity, skill mix, all of those things that we talked about before. So when looking on the med-surg unit, we also have discharge planning, social services, quality, risk management, utilization review, infection control. And we're just not looking or evaluating these positions and adjusting them based on volume and need. We know these positions are very essential and extremely important, but some facilities, it's still a full-time position for each of these disciplines, and perhaps some of these roles and responsibilities could be combined. For those of you in a union environment, collective bargaining agreements are often loosely interpreted or they're not clearly understood. We know some states have very definitive laws for nurse staffing committees. I recently was assisting a client out in the state of Washington, and they require nurse staffing committees they have to review their plan annually and submit it to the Department of Health annually when it's updated. Very specific. So, but how people interpret their contracts and interpret laws and things can vary greatly. So I know one thing we're required is to make a good faith effort and to provide staff with uninterrupted breaks. And there's a lot of different ways that people are doing that out there, but we have seen where folks are actually staffing an extra person that's not assigned patients just to relieve for breaks. What happens when we do all these things? Our hours per patient day creep up on us. As our patient days decline, we don't adjust our staffing, and our staffing patterns and our care delivery systems don't change. And all of a sudden we've just crept up and we just look like our hours per patient day are what we normally would see in a critical care unit. So then we have to think about it's really seen as a takeaway. So nurses get used to that staffing at a certain level, and change is really difficult. And then we start hearing things like we're going to start compromising patient safety and things like that. So what we typically see when we work with med-surg units is about 8 to 10 hours per patient day is industry standard. And we've seen hours per patient day as high as over 20 hours per patient day in facilities that we've been working with. We know it can be hard in really small facilities because you need to have base staffing. And if your average daily census is very low, it can be really, really difficult to accomplish an 8 or 10 hour per patient day. So then we also need to look at our processes. We have charge nurses, other licensed staff performing tasks such as assembling charts, putting together diet lists, doing those. We're not utilizing our staff to the top of their license. So we also don't have formal processes for admissions. We've been at facilities where an admission just comes up to the desk and says, they have their orders in their hand and say, I'm here to be admitted for Dr. Jones. And nobody's ready, nobody's prepared, we don't have a room prepared, we don't have a nurse assigned, and it just causes chaos. And everybody appears disorganized, and it just really leaves a poor impression with the patient. And then nurses are performing the registration process. They're taking the patient to the room, trying to perform the registration process, and this also could be performed by non-licensed personnel. We aren't setting a clear expectation for documentation to be performed at point of care at the bedside. And then we hear frequently that there's connectivity issues. Most of the time we're still seeing nurses come back to the nurses station and batch their documentation instead of documenting at the time care is given. I've seen facilities with beautiful computers mounted on the walls or computers on wheels. They have wonderful carts. So they have the tools they need to do it. But when we ask them, so why aren't you documenting at the bedside and doing it while you're giving care? We often hear that because I'm in the middle of my documentation, I'm documenting, and all of a sudden the screen freezes up, I lose all my documentation, and then I have to start over. So then a lot of them are waiting until the end of their shift, batching up all their documentation, and those are the nurses that we see sitting at the end of their shift trying to get all their documentation done. So this is going to obviously increase the potential for error because you're trying to remember which patient had what, and it's just a very poor practice. Bedside report is not practiced. Many facilities are not practicing bedside report. They're still holding bedside report in a conference room, and each nurse is coming in and reporting on their patients that they had for that shift. And nurses are continuing to enter orders for physicians who are writing or giving verbal orders. Moving on to the intensive care unit, we're still seeing dedicated units, and maybe there's only an average daily census of 1, and we're staffing 2 nurses. Just feeling like it's not safe to leave 1 nurse with a patient, but however, patient acuity levels are really more similar to a step-down unit rather than a critical care patient level of acuity. And oftentimes bedside and vital sign monitors are not interfaced with the EMR. So it's a manual process to enter vital signs. And it's the same with OB or Women's Center. We're having dedicated units, and average daily census may be less than 1. And we're really talking about 3 areas when we talk about obstetrics: labor and delivery, nursery, and postpartum. With a dedicated unit for obstetrics, we often do this for patient safety, so that we have to think about mom and baby and infant abduction, so that we can lock down the unit and have limited access to the unit. Again, as I mentioned earlier, we're keeping that labor and delivery nurse in-house without a patient assignment in the event that that laboring patient comes in. And depending on your situation, your location, where your facility is at, it may be appropriate to always staff that labor and delivery nurse. Having them without a patient assignment is something that we're going to talk about a little bit later. Training and competency needs are excessive and expensive. Obviously, this nurse needs to have a specific skill set, as well as the ICU nurse. Orientation can take a considerable amount of time if you have low volume of births. Staff may need to be sent to neighboring facilities for orientation, and that's obviously going to increase your cost, because you'll have travel costs, maybe some overnight stay. Maintaining competency can also be challenging and expensive if you have a low number of births at your facility. One facility that we worked with sent their staff to another facility for a 4-week orientation, and then 2 weeks every year to maintain competency. This particular facility had less than 50 births a year, so it was really challenging for them to maintain their competency of their staff. And what a huge commitment for this facility to want to maintain that service for their community, but obviously it came at a cost. And then keeping surgery and anesthesia on call after hours, especially if C-sections are the only emergency procedure you're doing after hours. That again is another huge commitment. And oftentimes we contract anesthesia services, so that's going to really run your contract dollars up if you're maintaining on call for C-sections alone. Then in the emergency department, we staff our emergency departments oftentimes based on instinct. We build our staffing plans because we always know that typically after hours, it gets busier. After clinic hours, it gets busier, but we don't have any specific time studies to support our staffing plans. Use of cheat sheets for documentation, just like we've talked about, it's common practice. Documentation's completed later. And we're doing that batch documentation instead of at the bedside at the time of care. And we know in the emergency room there's going to be plenty of times that it's not going to be able to document real time. When you've got a critical patient, codes, traumas, you can't. We know that. But there's plenty of times that there are times when you can document at the bedside real time. So you just have to weigh that out. We often hear that patients are overflowing to other areas, but we don't have any data to support how often it's happened or why it's happening. Is it happening because you don't have enough rooms, or is it happening because you don't have enough staff? There just isn't any data supporting that. And extended stays in the ED that are meeting criteria for observation, such as a rule out chest pain. You've got a rule out chest pain that's waiting for serial labs, and we're keeping them in the ED for 12 to 24 hours, just waiting on lab work. Mental health patients, those are another ones we commonly see as extended stays in the ED. And poor relationships with EMS. This is kind of a sensitive issue, but you do want to be close friends with your EMS. Patients have a right to be included in the decision for what facilities they're taken to. Now, generally, we know EMS take patients to their nearest facility, but we have seen cases where if there's more than one facility that's the same distance from where they're located, EMS is going to encourage patients to select a facility based on past experiences with an organization. The other thing is I've seen where EMS was completely unaware of services that a facility offered. They had one facility had a visiting orthopedic that was providing services there. EMS had no idea that this facility had orthopedic services, so they were just bypassing them and going to another organization. So make sure that they're aware of all of the services that your facility provides. And again, hours per visit are, we usually use a benchmark of 2.25 as the industry standard, and we've seen them as high as 5.63 hours per visit. In surgery, we're continuing that 24/7 call coverage. After analysis of minutes by time of day of the week, after hours cases are minimal or almost non-existent, and majority of them are non-emergent and could be scheduled that next day. However, facilities just really don't want to let go of that, offering that 24/7 coverage. Most surgery departments have a set staffing pattern, and they're not adjusting to case volume. So even if no cases are scheduled or cases are done for the day, the staff continue to work. I'll hear, well, there's paperwork to do, or we need to do PAT calls or follow-up calls, but what's happening is it's just pushing up those hours per case extremely high. Surgery is one area that we rarely see staff float. It's a very specialized area, so it's probably most often where we see that staff don't float. And as I said, hours per case are well over the industry benchmark. We've seen some real efficient departments running as low as 6.8, but we have also seen some others that have been as high as 29.75. So benchmarks vary based upon the types of cases that you're doing. So endoscopies, for example, we typically would use a benchmark around 4.5 hours per case. Surgical cases typically would be closer to 8, and cataracts should be running as low as 2 hours per case. So as we talked, the surgery schedule is not adjusted to case volume. And what I'm talking about here is the physician's schedule. So this is just an Excel spreadsheet I put together just super quickly. It's most of the time smaller facilities are not using a true block schedule, but more of a modified block schedule. So surgeons may be given a day of the week or partial day of a week, but they're rarely meeting 30%, 50% utilization, if we even have data to know what their utilization rate is. However, they just continue to maintain those hours of operation 5 days a week, and we're not adjusting block times or anything based on utilization. And first case late starts is another area that we're just not tracking, we're not monitoring. I often hear from staff that it's a chronic problem, especially with certain physicians. However, we're just not monitoring it. And first case late starts sets the stage for the entire day. Potentially the rest of the to follow cases for that day are going to be late as well if your first case is late. Some facilities are so small, they maybe only have 1 OR room running or 2 OR rooms running. So you can imagine if that first case is late, you're late for the day. And so your late starts are going to affect your patient satisfaction, your staff satisfaction, and can affect physician satisfaction if you've got another physician that's late because that first physician was late. So if you're not starting on time, you're not finishing on time. So I have our first polling question.
First polling question is, does your facility have a staffing plan that is updated at least annually?
Well, great. 48% of you do have one that's updated annually. That's awesome. For those of you that don't, it's something you probably want to think about. Okay, so why? let's get into some of the reasons why we feel like we're unsuccessful. So we hear we've always done it this way. Doesn't everybody always love that when we hear that? We've always done it this way. That's one of my favorite responses, and it's going to make me work very hard to find reasons why we can do it better. We often hear we're unique. Everybody wants to think they're special, and we are special. And every organization does have some uniqueness in your reporting structure, your physical structure of your department, workflows, the population you serve, but there's also a lot of similarities. In small communities, everybody knows everybody, everybody's friends, managers are managing friends, so it's tough to make it's hard to make those tough decisions and implement changes. It's personal. And you're often the largest employer in your communities, so you're worried about those positive communications, those positive community relations. That word of mouth can be such a huge influence on your reputation in the community. And managers are concerned for their employees. We often hear, well, we're worried about our staff. They need their hours. We can't call them off because they need their PTO. And then concerns that physicians will take their business elsewhere. If we start talking about late starts or we tell them they can't have all their block time, then they'll just go somewhere else. So we know that change is difficult, but not changing may be fatal. So I saw this quote. I don't really know this person, but I liked it. So as you move outside of your comfort zone, what was once the unknown and frightening becomes your new normal. So really the bottom line is, if we don't right-size our organization today, we may not be here to serve our communities tomorrow. So really, if we're not managing our staff, we're doing that disservice to our community and to our staff. Now we'll go to our next polling question. So how open do you feel like your staff is to change? So, yep, do you have innovators and early adopters that are just saying, let's do it? Or early and late majorities that say, let's just give it some time, let's talk about it some more? Or those laggards that say, it's fine the way it is, why do we need to change? Yeah, I would say that's what we typically would see. That's very common. Okay, so now let's get into what you can do. And there are lots of things that we can do to help with our staffing needs. So we can start with maximizing efficiency. We talked about utilizing staff to the top of their license. So unlicensed personnel need to be performing things like putting together charts, making the diet lists, registering patients, transporting patients, doing those basic cares. Utilize your licensed personnel to perform those basic or perform patient assessments, developing care plans, carrying out physician orders. Some of this may mean taking a hard look at your care delivery system and making some drastic changes. Determine the need for separate specialty units. We talked about ICU and OB. Look at your volumes. If you've got that average daily census of 1 and you're staffing 2 nurses, does the volume support a separate unit, a separate ICU, or would a monitored bed on med-surg meet your needs? Look at the acuity of the patient, understand how critical they are, what type of intensive critical care do they require? Are they really requiring the type of care that would mandate a separate unit? Or is it something that could be done in a monitored bed on the med-surg unit? There's a lot of advantages to having a monitored bed on a med-surg unit versus a separate unit. Patient safety, because you've got plenty of backup for nursing. They're not so isolated. You've got physician efficiency, because they're not having to call another unit or round in another unit. Their patients are all basically in one location. And nursing efficiency and nurse leaders efficiency, because of easier scheduling and easier to find their staff as well. If you do decide you absolutely need to keep that dedicated ICU, really think about determining if 2 RNs are always required. Depending on how remote and isolated your ICU is, that's one consideration. And just looking at the acuity of the patient. What's the diagnosis? How critical are they? If they're very stable and they're just there to be monitored, could you assign someone on med surg that's the backup on-call person, so to speak, for that ICU nurse, that they really don't need to have 2 nurses assigned in the unit? When we talk about OB, as I mentioned, it's a little more unique because we need to be concerned about the safety of mom and baby and taking precautions to prevent that infant abduction. So the dedicated unit obviously has advantages because traffic can be controlled and you can lock down the unit. You also have infection control concerns that you have to be thinking about and cognizant of on the med-surg unit. If you're fortunate enough that there's a separate wing or a designated area on med-surg that you could utilize, then that may be a consideration. Joint Commission best practice guidelines for preventing infant abduction does include implementation of an infant security tag or alarm systems, or as well as controlling access to the maternity unit. So depending on your facility's volume of births, how close is the next birthing center, how isolated is your unit, this can really pose some challenges for staffing efficiently. Evaluate your services to ensure they are appropriate for your facility. In talking about, obstetric services, we typically recommend at least 100 births a year to remain competent. We talked about how challenging that can be, keeping nurses competent, and what a commitment it is for your organization to continue to offer that service. So if that's the only reason you're keeping anesthesia and surgery on call and maintaining that competency, it's something to really consider. And again, how close is the next birthing center? There's so many things that you need to consider here, but it is definitely a commitment for your organization if you're doing less than 100 births a year. Develop clear processes for admissions. Physicians' offices really need to be required to give proper notice. If you've got proper notice and you have a process in place, staff can have a room ready, assign a nurse, and everybody looks prepared and the process just goes much smoother. You're going to increase your patient and your staff satisfaction. Have registration staff perform the registration process, whether the patient stops at registration on their way in or registration staff comes to the patient. I think the trend is becoming more and more to bring services to the patient and prevent the patients having to go from department to department, but that's just going to depend upon if that can be accommodated at your facility. Implement bedside reports. Bedside reports are a very efficient way to share patient information and hand off the patient to the next caregiver. Patients have a need for increased involvement in their care, and one way you can achieve this is through bedside report. So there's a lot of benefits to bedside report, but patients would have an increased knowledge of their condition and treatment, less anxiety, and it's shown to increase patient satisfaction. On the other hand, bedside report also increases team building and improves communication among your care team. And it's been shown to decrease the time needed for shift report and that time for past shift time for report. We also need to set clear expectations to document at the point of care. That use of cheat sheets and batch documentation practice has to stop. It's inefficient, it's duplication of efforts. If we're writing it down on a cheat sheet and then our report sheets, wherever we're writing it down, notes, and then going back and documenting, you're essentially documenting twice. Plus there's potential for error. If you've got multiple patients and you're doing your patient assessments and then you go back to document, can you be absolutely sure that you're documenting the right assessment? There's just potential for error. And the information isn't readily available for the next caregiver, whether that be the physician, the pharmacist, the dietitian, whomever's looking for information, that information needs to be readily available. Nurses who wait until the end of the shift to document, those are the ones that are often clocking out late. I've seen organizations where there's chronic offenders, and these are the ones that you see as chronically late getting out of their shift on time. It may be beneficial to track it for a time just to see if you feel like this is a problem. Track the hours past shift and then look for those chronic offenders and set some clear goals, clear expectations, and then celebrate wins if you see improvement. So it's amazing how those hours past shift can add up and how that can affect your productivity. Adopt provider order entry. This is something that I'm very passionate about, and it's just something that needs to be adopted by all providers. It improves patient safety, it increases efficiency, and it improves care coordination. And make sure your patients are in the right status. If they meet the criteria for observation, admit them, get them out of the ED. Certainly your patient is going to be more comfortable. Nobody wants to lay on a cart for 12, 24 hours. I know this is this can be really challenging, especially for some of those mental health patients. And I don't have a good answer for you. I wish I did. I know some facilities will keep them in the ED because they have an easier time getting them accepted to another facility if they're still in the ED versus if they're admitted to observation. I guess all I can say is really develop relationships with those facilities that you frequently transfer to, maintain a good relationship, and we just need to do the right thing. What's the right thing for the patient? Adjust staffing to volume, establish benchmarks. We need to have benchmarks because if we don't have a goal, staff don't know what are we working towards? What are we supposed to achieve? Provide education on the benchmarking process, the budgeting process, so that everybody understands and we get buy-in from the staff. And then utilize a staffing matrix. Once a benchmark is agreed upon, the matrix is a great tool that determines staffing needs real time. It's now. When we get our productivity reports and our monthly budget reports, it's at the end of the month. It's too late. We can't go back and change anything. We're always playing catch up. And don't be afraid to make adjustments mid-shift. Oftentimes we're so stuck in, this is our staffing, and we're always looking to the next shift, what to staff for the next shift. Unless, of course, we're getting buried with admissions or we need more help, then we're always quick to ask for more help. But we don't always remember that if we've had a bunch of discharges this morning, it's okay to send somebody home or float somebody to another unit. But we have to get out of that mindset that we can downsize mid-shift as well as we can ask for additional staff mid-shift. Review those low census policies, ensure it's current and it's fair, it's up to date, we're following it, and stop staffing for what ifs. Every day, every shift is different, and we have to be critical thinkers. We've got to have those robust staffing plans in place so that we can handle those unplanned admission, all those events that happen that we can't think of everything. And yes, it may be appropriate to have that labor and delivery nurse in-house so that we're ready for that laboring patient, but our staffing plan needs to address what we do if that laboring patient comes in. So she's going to take a patient assignment, and Susie's going to take a patient, Jill's going to take a patient, and Mary's going to take a patient. So Lori can go deliver the baby. And if that's not going to work because everybody's maxed out with their patient load, maybe the charge nurse has to take the patients. If the census is too high and we really need the charge nurse not to take patients, then maybe it's having somebody on call at that point. Every scenario, it could be different. So we really have to be robust in our staffing plans and planning for all of those things. Perform a time study in your ED. Really analyze those peak times of ED utilization. I know we all have instincts, and many times our instincts are right, and the time study then will just validate what you're thinking, or a lot of times we might be surprised. But either way, it's going to justify your staffing needs so you can develop a staffing plan and budget appropriately. And sometimes you may, if you live in an area where you have a tourist, a seasonal changes in your staffing needs because you attract tourists during certain times of the year, you may have to include that in your staffing plan. Develop a reliable method to track how often patients overflow to other areas. So this is challenging. I know I've seen many places it's a manual process, but if you're overflowing to other areas out of the ED and you feel like this is happening frequently, you need to figure out why. As I said, is it because you don't have enough rooms, you don't have enough places for patients, or is it because you don't have enough staff to handle the influx of patients? So utilize your EMR. Is there a way to pull a report from the EMR that you can get that information? Many times we maybe document the patient, don't put the patient into the EMR until we room them. So if you have patients waiting in the waiting area, you might not capture that. I know we have a logbook perhaps that you log them into the logbook while they're in the waiting room. So just figure out a way to capture this information, preferably in an EMR. And then once you determine the reason and the frequency of your overflow, that's really going to dictate the action plan that you'll develop to address your issues. Perform an analysis of your surgery minutes by time of day, day of week, and by surgeon. This is going to help you determine the hours of operation and the need for 24/7 call, and monitoring block utilization and late starts. Block utilization, you need to be sure will help you determine if you have surgeons in the right block, and it's going to support those hours of operation as well. Maybe you can put more than one surgeon on a day and consolidate your schedule. If you have opportunity for first case on-time starts, then this should be a goal as well, and chronic offenders need to be addressed. These are tough discussions to have with surgeons, but surgeons need to be involved in the discussion. And a lot of times it's just developing the definitions. What is start time? Is start time when the patient is scheduled, or is start time when the patient arrives in the room? Is it cut time, or is scheduled time when you take the patient back to the surgery suite, or is it when you have the patient ready on the table, ready to go? So there's just a lot of misconceptions that can happen that can just nobody's fault, but it leads to a lot of frustration and delays. So it's really important that you have open dialogue and good communication, and then documentation to make sure everybody's on the same page. Then once you agree upon these definitions of your start time, of your scheduled time, then it's time to set some goals and some expectations. So 80% on-time first case starts, and everyone needs to be clear on your expectations, your surgeons, your surgery staff, and then start monitoring it. And monitoring it on a regular basis. We set our goals, we monitor it, and we have expectations of what's our plan if we're not meeting our expectations. So we set a time frame for reevaluation. We're gonna monitor, we're gonna share the results with each individual surgeon, say quarterly, and then we reevaluate. And perhaps if block utilization doesn't support 5 days a week, maybe then we're going to consolidate the schedule and go to 4 days a week, or at least we're going to have those discussions. So this is just a sample of surgery minutes. Obviously, this facility most of their procedures took place at 10 o'clock in the morning, but it can really be helpful to show you that when the bulk of your procedures are taking place. This is by time of day, but you would do the same thing by day of the week and by surgeon. So you would see case volumes, block utilization, but just really gives you a good idea of it's very, very helpful in planning your schedule. Then moving on, we need to staff effectively. So cross training. Staff should really be competent to work in at least 2 areas. This is going to make your staff more versatile, so avoids cutting staff, expanding their skills, and it has been shown to increase staff satisfaction overall. As I've mentioned, OB and surgery are 2 areas that frequently don't float due to their specialization. And we need to value that skill set, but we also have to work towards our productivity goals. So floating is never anything that nurses jump on. I mean, it seems to be not something they're excited about. So some things that we can do is let them choose maybe where they want to cross train to. They'll be more comfortable if we provide obviously good orientation and training, and maybe think a little bit out of the box and do some of those non-traditional things like maybe the trauma stroke coordinator duties or infection control, some of those things that we typically don't have staff float to if you have a need in your organization for something like that. Evaluate roles and responsibilities. We talked about discharge planning, social services, utilization review, and as I said, these positions are very important, and so this does take some thoughtful consideration. But there are benchmarks for each of these positions, and maybe some of these responsibilities can be combined and not all require a full-time position. So I've seen facilities that staff discharge planners on the weekends, and based on what the number of discharges your facility may have on the weekend, maybe that's appropriate, but it's really something that we need to evaluate. And develop those EMS relationships. Conduct trainings where you invite EMS staff and they participate with your ED staff, and include the ED physicians. Conduct trauma, mass casualty drills so that EMS build a confidence in your ED and have a relationship with your ED physicians. Do everything you can to ensure a strong supportive relationship with your EMS. They're going to be more likely to stick around and assist in a crisis to help stabilize a patient rather than just drop the patient and leave. They'll stay until the nurse is comfortable and help work with that nurse rather than just, I've heard dump and run is the terminology I've heard people use. Review your staffing plans. They should be reviewed regularly, at least annually. Make sure they're still appropriate. I know many of you have a staffing committee that's reviewing your staffing plans. And if you have a collective bargaining agreement, if you're in a union environment, make sure you've got a good relationship with your union representative and that you thoroughly understand all the elements of that collective bargaining agreement. If you don't, ask questions. Don't be afraid to ask questions. Make sure everybody's on the same page. Have good open dialogue in your staffing committees and between your union representatives. And we talked a little bit, I mentioned, the uninterrupted lunch breaks and the breaks and making sure that staff are getting their breaks. There's a lot of ways to accomplish this without staffing a person that doesn't have an assignment that's just going around relieving for breaks. So get creative, utilize some of those. Maybe it's some of those folks like the discharge planner or the infection control nurse, some of those that we don't think about utilizing to help relieve for breaks. Most of the time staff can relieve each other for breaks. Occasionally there's shifts that are just so busy they don't have time to do that, but that's where we need to get creative and start thinking about how we can relieve people for breaks. Ensure services are in the right location. With infusion services, wound care, all those things that we offer patients, seen them located just about anywhere, and it's really going to be determined by your facility. What's going to work for your facility and where it makes most sense in your organization. I've seen infusion services in wound care in the ED. We've seen them in same-day surgery on the med-surg unit, and there is no right or wrong. It's going to just be where do you have the staff that you feel can absorb the volume and has the best access for patients. And utilize your EMR to its full potential. Work with your vendors to build reports so data can be automated and eliminate manual processes for data extraction. Manual extraction is so time consuming and such a poor utilization of resources. And it's something that's so necessary for quality. We're always data mining, looking for data for many different reasons. So if we can build reports, and most EMRs have the capability, the functionality, it's just a matter of working with your vendors to build the reports. Auto-populate fields when possible to eliminate duplication of efforts and eliminate the potential for error. Sometimes a patient's admitted from the ED, for example, and could there be something from the ED that auto-populates into the nursing admission assessment? The chief complaint, for example, or from a previous assessment, can it populate to this assessment? Anything that can auto-populate to save time. Utilize templates for documentation to standardize and eliminate the need for free texting. Documentation needs to be intuitive. Nurses have so many things on their plate to remember. There's so many regulatory requirements, so many things we need to document for quality, so many things we need to document for payment. So they can't remember everything as hard as they try. So if our documentation is built correctly and works as designed, it should be very easy and very intuitive. And if we have a point and click, it's much faster than if they have to type out and free text everything. So work with your vendors again. If you have someone that's a good representative from your vendor, they can help you build your documentation so that it's intuitive and it's easy and it flows well and it's going to meet all your regulatory requirements. Interface equipment, such as your vital signs and cardiac monitors, to eliminate the need for manual input. This can be very expensive, especially if you add it later. So anytime you're planning on buying a piece of capital equipment, always include this upfront in the original quote. Whenever you're getting a quote for anything, always ask, what's the interface cost? Can it be interfaced with my EMR? And what's it going to cost? Always don't forget to ask that anytime you're buying something new, because once we go to add it later, it's going to cost you twice as much. Ensure that staff have the tools to document at the point of care and address connectivity issues. I more often see the connectivity issues rather than having the tools they need. But the connectivity issues just really have to be addressed. We lose productivity when information's lost and it has to be recreated and documentation's duplicated. Patient safety is compromised when information's lost or there's a delay in access. Data entry can be very important in the plan of care. Vital signs, oftentimes we're dosing medication based on vital signs. I was with a facility and they had their vital sign machines interfaced, but it was a frequent issue where they would lose connectivity and the vital signs would be lost. And so then they were recreating vital signs. Well, in an emergency room, this is an issue because you're dosing medication, you're basing your plan of care. There's a lot of things that it can be a very risky practice and a huge potential for errors. So these types of things need to be addressed and reported it just needs to be addressed and they need to be handled by your IT staff in a timely manner. And this is what we all want to do. Wouldn't we love it if we could all increase our volume? So market your services. Let our communities know what services you offer. Why should they come to you over the place down the road? Members of the community most likely know many of your staff. If you're a smaller community, staff probably know a lot of it. So showcase them. Showcase your staff in the community as well as your physicians. Don't forget about marketing your physicians, especially new physicians. And don't forget to market to your physicians. Make sure your physicians know all of the services that your facility has to offer. Do you have a physician orientation process? When you get new physicians in your area, do you bring them in and do formal orientation so that they are thoroughly aware of all of the services that you have to offer. And when you get new services, make sure you do a big marketing campaign about that service and the staff that will be involved in that service and the physicians involved in that service. Improve accessibility. How fast are patients seen in your emergency department? How fast are they scheduled? If they call and they need a procedure, how fast can they be scheduled? I was recently at a client's and I was in the hotel room that morning getting ready, and a commercial came on for a facility down the road, and they were touting that they could be seen in their emergency department in 20 minutes. So I asked when I went to the facility that morning how fast they could be seen at their facility, and they said, well, it's almost immediately. And we looked at their data and it was like less than 10 minutes. And so, you know, I said, you need to be sharing that. And those are the things we need to be sharing with the community, letting them know how fast they can be seen in your emergency department and scheduled. Many places they're scheduling out for weeks or even a month or more than a month. And so let them know they can, if you want this done here, we can get you in next week. And I keep saying this, I keep mentioning building the relationship with your EMS. They're going to encourage patients to select your facility if they have a good relationship with you and they have confidence in your abilities. They need to know what your services are. They need to know that what your organization provides for services. If they have confidence, they're going to encourage people to use your services, and they're going to be marketing out in the community just as much as anyone. So broadcast your quality measures. If you're doing well on your patient satisfaction, your infection rates, all of your quality measures, get that out there. Let folks know. Let your community know how well you do. And look for trends and transfers to ensure they're appropriate. If you're, monitor your transfers out of your ED, especially those transfers on weekends and after hours, and look for ones that are being transferred that have services that could have been provided for services that could have been provided at your facility. And medical staff should be involved in those reviews, in that review process. All right, polling question number 3.
Okay, polling question number 3. Do you have reports available at your facility to view surgery minutes by time of day, day of week, and by surgeon?
Oh, good. 43% of you do. That's awesome. Very good. All right, so what can Eide Bailly do for you? Well, we can provide a staffing analysis. We can come and perform a detailed staffing analysis, make recommendations on a care delivery system that will work for your organization. And along with a staffing analysis, we do a productivity analysis where we will set benchmarks and benchmark recommendations, and not just for these departments that we've talked about today. I've just picked a select few focusing on the nursing departments, but we can really do any department within your facility. And we can provide a staffing matrix. We have a very wonderful tool that will predict your staffing needs on a shift by shift basis. We can assist with development of an implementation plan for a new care delivery system or staffing plan. We can come on site if the client would like us to come on site and provide support side by side. We have staff with leadership skills and expertise that can mentor and provide guidance for nursing leaders. And we can do this either remotely or on site. And we're always here for questions and ongoing support following implementation. If there's questions, I'm always answering questions, getting phone calls. So we're always here for that. And remember, if the plan doesn't work, we change the plan, but we never change the goal. Questions? We have plenty of time. It's 2:04, so we have plenty of time for questions.
And the only question that has come through is, what is an example of a staffing plan? Our organization has never had one.
Oh, that's a good question. Staffing plans can be it's hard to just spit that out. A staffing plan would be something like, based on census. A very simplified staffing plan would be for a census of 3, we staff 2 nurses. And if for a census, and it's based on census, but then in addition to what we like to see, not just based on census, but also included in there is activity. So as I said, so some type of an acuity system. So we've seen many, many, many types of acuity systems. So if a patient has this many medications, do they have 1 IV or 3 or 4 IVs? Or how many IV medications are they getting? Are they on oxygen? Do they require suctioning? Are they on BiPAP or CPAP? Do they have an NG tube? Do they have a Foley catheter? I mean, there's just all kinds of things like that then. And then based upon all of those needs, they're given an acuity number, so to speak. And then based on that number, then nurses are assigned patients so many points for however, like this patient 1 has an acuity of 4, patient 2 has an acuity of 3, and a nurse can be assigned up to an acuity of 10 or 15. That's a very simplified version. And then that's your staffing plan. And then you can go on down to those what ifs. If a laboring patient comes in, we always staff a labor and delivery nurse. In the event a laboring patient comes in, this is what happens, and those types of things.
I have one more question here. What was the industry standard for ED hours per visit?
2.25.
That seems to be the end of the questions. And you can always reach out to Lori if you have any direct questions.
Absolutely.